Thank you, Harry,
Thank you,
and thanks for the invitation to speak here. My presentation is going to be slightly different from the last speakers. The history of surgery is a very colourful one. It all started about 10,000 years ago with trephine skulls, or people who basically had holes bashed in their skulls. You'd wonder how long someone could survive with a hole in their skull 10,000 years ago, but from excavated skulls that they've studied, people have lived not only weeks and months, but even years with this. Why exactly people were bashing holes in each other's skulls is not quite clear, but it might have been due to maybe people trying to release some demons that were in the people at the time. So flash forward a number of thousands of years, and the next area would have been the barber surgeons. These would have been travelers who would have gone from city to city, making a big spectacle and a show of cutting bladder stones out of people. I'm not quite sure why bladder stones were so common back in the 15 and 1600s, but the idea of the barber surgeon, and you can see there a picture of a very famous one called Frère Jacques, and the idea was to cut the stone out as quickly and as bloodlessly as you could while the person was pinned down. Then a number of years later, there was the body snatchers who were stealing bodies from graves so that we could then learn about the anatomy of patients, and subsequently we learned about the physiology of the body and how it actually worked. And then there was the grand spectacle of surgery being performed in auditoriums, which is why, of course, they're called operating theatres, because the operations were performed in front of tens and hundreds of people on occasions. Of course, the surgery wasn't particularly successful at that time, and it wasn't until we developed general anesthetic, the actual instruments to be able to perform the surgery, and then antibiotics, that surgery subsequently flourished. And it's got to a level whereby not only can we perform operations to repair organs and make things function properly, but we can even take an organ out of one human being and put it into another human being, and they will survive. Laparoscopy, or keyhole surgery, was also developing in the background about 2,000 years ago, when Hippocrates had generated proctoscopes. In the 1500s, there was something called the Lichterleiter, but it wasn't until the turn of the last century that people started doing what we would consider the foundations of laparoscopic surgery, which was looking inside the bellies of dogs. Of course, people would have thought, why are you doing that? You can't see anything, you can't do anything. So they would have put lights onto the viewing scopes, and then they would have put gas into the abdomen, and then they would have developed instruments. And gradually, over a period of about 80 or 90 years, keyhole surgery was developed. It was mainly developed by gynecologists, it has to be said. The first laparoscopic appendicectomy was performed by a gynecologist called Kurt Sem in 1983, and he presented this at a meeting, and he was subsequently referred to the German Medical Council, and they tried to have him struck off. About 4 years later, when there was a combination of closed-circuit television and optic fiber technology, was the first laparoscopic cholecystectomy, or gallbladder removal operation, performed by a French surgeon in Lyon, and that quickly became the gold standard for surgery. Keyhole surgery, or minimally invasive surgery in general, had certain benefits that were offered to patients, such as a shorter hospital stay, less requirements on analgesia, less post-operative pain, and earlier return of bowel function. So it quickly began to be used not only in gynecology but also in general surgery in all areas. I recently spent some time in a unit in France, in Strasbourg, in the IRCAD unit, and these were the major advances that they had produced there. The top left operation is something called Operation Lindenberg, and what you had was a surgeon sitting at a console in New York operating a robot that was removing a gallbladder of a patient in Strasbourg. They had approached the French military for their help to see if they could use their satellite systems to make this work, and they said it was impossible. So the story goes they went to French Telecom instead, and they were able to do it. The top right operation is something called Operation Anubis, and this is something called NOTES surgery, or natural orifice transluminal endoscopic surgery. Basically, a colonoscope was passed either through the stomach or transvaginally, and a cholecystectomy or a gallbladder operation was performed as well. The aim of this type of surgery is that it would be scarless surgery. On the bottom left, if I can get it to play again, there are endoscopes had been designed back in the late 60s and early 70s, but hadn't changed much in their design over those years. But they've started developing special operating endoscopes. So you would have a colonoscope that could not only travel to the site, but could also perform an operation. But these things are still very much under development at the moment. There we go. Colorectal cancer is very common in Ireland. There's about 2,500 new cases every year, about 1,000 deaths every year, and it would represent 12% of all cancers in the country. Luckily, it does have a good outcome, about 60% 5-year survival for all comers or all groups, which is very good as compared to something like pancreatic cancer. And the stage 4 disease, the median survival currently is at around 3 years. It was always thought of as a disease of the elderly, but we are seeing more and more that it is creeping into a younger and younger age group. The staging of the disease, in simple terms, is a small tumor, a large tumor, tumors that have spread to the lymph nodes or else to distant organs or distant metastases. And the 5-year survival changes dramatically from each of the stage, with a 95% stage 1 survival, decreasing to 70% for stage 2, 50% for stage 3, and then less than 5% for stage 4. Ireland, the incidence or the number of new cases of colorectal cancer every year is slightly above the European average at nearly 35 cases per 100,000. Cork, the incidence is nearly 60 per 100,000. It's worth saying that again, the incidence of colorectal cancer in Cork is nearly twice the European average. The National Cancer Registry Institute, or the NCRI, have recently published an analysis of 15 years of colorectal cancer outcomes in Ireland. And we can see that the Bon Secours in Cork is the only private hospital that makes it up into the top 24 of the list. We have a very large team to help deal with the colorectal cancer in the hospital. It all starts with the referral in from the GP. Then there is endoscopy, radiology, histopathology to get the diagnosis, oncology, radiation oncology, which is the main reason we're here today, because of the new build in the back of the hospital, where we will be providing radiation oncology from July 2019. We do need a surgeon to cut out the tumor, multidisciplinary meetings, operating theatres, intensive care units, high dependency units, physiotherapy and occupational therapy, stoma therapy, pharmacy in multiple different sites, perioperatively, and also from an oncological point of view in dealing with the chemotherapy, and also a huge nursing complement that would feed into nearly every single one of these areas. Also, we need the hospital and the management team behind us believing in what we are doing and providing for the patients. And we do have all of these pieces of the jigsaw in the Bon Secours in Cork. The indications for colonoscopy, which is the test that provides the diagnosis and identifies the tumor for us. It is a very common test. The symptoms that we can see from colorectal cancer vary very widely. The most common one would be bleeding per rectum or PR. Any unexplained abdominal pain would need to be investigated. Changes in bowel habit that are persistent over a period of time. Unexplained weight loss. Any iron deficiency, anemia, and any masses that are palpable, either PR or on abdominal examination. There are a number of cases that would stand out in my mind over the last year alone. There was a gentleman in his late 60s who had very little symptoms for about 2 or 3 weeks of passing a bit of mucus, who had a very advanced rectal cancer with metastases. We had a young 40-year-old who went for a health screening check, was found to be anemic. We did a colonoscopy, and she had a tumor of the right-hand side of the colon with liver metastases. And I must say, we are seeing younger and younger patients coming in with colon cancer at the moment. Surgical outcomes is something very true to my own heart, that there's no point in trying to provide care unless we can get the best standards for the patients. That's why we are here. Volume and surgical outcomes would have been a huge issue around the early 2000s. And there was a very good publication in the New England Journal of Medicine in 2000, which looked at a number of different operations. But the biggest difference that they found was for esophagectomy. What they found was that in a high-density area, for example in New York, if a patient paid the $1.50 to get the tube down the road to the cancer-dedicated center rather than going to a local hospital, they could decrease their mortality from esophagectomy from 24% down to 8%. So the volume, or the number of cases that we're doing, and the team and the support that we have in place in the hospital is crucial to the good outcomes for the patients. This is something that the NHS have very much taken on, and they're now publishing individual surgeon 90-day mortality rates and also trust mortality rates, 90-day mortality rates across England, and that will be rolled out to Wales, Scotland in the future. This is free, open access. Anyone can get this data. Obviously, if you were a patient, you have the mortality going up on the left-hand side, and you have the volume going across the bottom. And if you were a patient looking for a surgeon to do your surgery, well, I think you'd pick this fella here. Very low mortality, but a very, very high volume. I actually know him. His name is Amjad Parvez, and he worked in the unit with me in Portsmouth a few years ago. Obviously, if you were to look up your own figures and see that you were up in the red area, you would be getting concerned. And I'm sure there are patients who are looking at this data regularly to try and see which surgeon they're going to be dealing with for their surgery. In terms of the outcomes then, there's been a lot in the press recently about endoscopy and colonoscopy with a number of incidental carcinomas or missed cancers coming out of Wexford in the last number of years. We are very much analysing our data constantly. The cecal intubation rate, the gold standard would be about 90%. We're over 95%. The polyp detection rate should be 20%. We're nearing 40%. And the adenoma detection rate should be over 9%, and we're well over 20%. When it comes to the different stages of cancer that we're dealing with, the main work that we would see would be in stage 2 and stage 3 disease. We are getting a large quantity of stage 1 disease, or very early small cancers, but we are also operating on stage 4 disease. And we have excellent links with the thoracic surgeons in Cork University Hospital, with the liver surgeons in the Mercer University Hospitals, and also with other units throughout the country to try and deliver the best care we can, particularly in the stage 4 disease, when it's very much a multifactorial approach that we need to get the best outcomes for the patients. The stage 4 disease that I'm showing here, that is only the patients who are having their primary tumor resected at some stage in their pathway of care, and there are other patients who wouldn't necessarily make it to the surgery of the primary colon tumor. In terms of the operative outcomes then, one of the main things would be the R0 resection rate, which is that the tumor is fully excised. The recommendations would be that it should be over 90%. We're over 99%. The 90-day mortality should be less than 5%. We're less than 0.5%. 30-day readmission rate should be less than 20%. We're less than half of that. Permanent stoma rate, or the number of abdominoperineal resections that are being performed, should be less than 30%. We're at less than 5%. Our lymph node yield is nearly double the required. That's the average lymph node yield. When it comes to patients receiving chemotherapy after their surgery, there is a limited time, or there's a peak time from finishing your surgery and receiving your chemotherapy, and that is an estimated 6 to 8 weeks. And we are very much in keeping with that, with those figures. In fact, none of our patients have not made their chemotherapy deadline as a result of the surgical complications in terms of wound infections or delayed because of wound healings. They've been either because of patient preference or because of major ischemic events such as heart attacks or ischemic bowels. The leak rate, it depends on what source you go to for this, but it should be at least less than 8%, and our own rate is less than 1%. This again is due to the team that we have built around looking after the patients, and also that it is a consultant delivered service that we are providing. So what is the future going to hold for surgery and colorectal surgery? Well, it's a little bit unclear. The video on the left shows you what is hopefully coming down the line in terms of robotics, and this would be a single port, small diameter delivery system that would then split into one camera and then 3 operating arms. The benefit then would be that you could conduct the robotic surgery in a much simpler fashion down smaller and smaller holes, making it more minimally invasive. The picture on the right that you can see is something that they're working on in the IRCAD unit in France, and this would be an integrated operating suite, whereby not only do you have robotics, but you have endoscopy, you have radiology, as well as image-guided technology to produce the best operations and outcomes that you can for your patients. Thank you very much.
So I think we have some time for questions, if anybody has one.
Is there any particular reason why Cork has double the rate than the European rate? What are you doing in Cork that we're not doing everywhere else in the country?
I'm not sure. I really am not sure. I would have thought that if there was any area that had twice the European level of incidence of the bowel cancer, that there would be a major public health campaign to identify why and try and figure it out, but I'm not sure. I'm not sure if it's the spiced beef or the Clonakilty black pudding. There is a lot of, maybe Dr. Bird might elaborate on this later, but there's a lot of work looking at red meat and the consumption of red meat and carcinogens that are used to preserve meat that may be factorial in it, and also viruses in the meat that may be doing it. But I don't want anyone to run off and become vegan on us just yet. It's unknown, but I haven't heard of a lot of public funds looking into the why, because like twice the European average is very high.
Okay, thank you, Brian.